for joining us for the School of Public Health's Global Health Programs speaker series. This is a monthly speaker series that we have. We've been really trying to make an effort to highlight our preceptors or our program partners through this series. So we're delighted to have Dr. Fred Oteño with us today from the Nyanza Reproductive Health Society. Nyanza Reproductive Health Society, or NRHS for short, is actually an organization that was co-founded by one of our emeritus professors, Dr. Bob Bailey. He's an emeritus professor in epidemiology, and it was co-founded several decades ago when he and his team were conducting randomized clinical control trials of voluntary medical male circumcision. So we're very excited to have Dr. Oteño here with us today. I'm going to start with a brief bio, and then he will proceed with his presentation, and we'll have time for a Q&A at the end of his talk. Please feel free at any time to submit questions in the chat, and then we'll try to get to your questions at the end. So, all right, so here, Dr. Frederick Oteño is a seasoned epidemiologist with over 20 years of clinical, administrative, implementation, and research experience in Kenya. Dr. Oteño is the current director of the Nyanza Reproductive Health Society, NRHS, overseeing the organization's administration, research, and programming. Over the years, Dr. Oteño has established a reputation of excellence in project leadership, strategy development, research, and monitoring and evaluation in HIV/AIDS, STIs, infectious diseases, adolescent health, LGBTI health, and reproductive health. He provides comprehensive strategic and operational leadership to ensure that all NRHS programming and research is quality, compliant, and technically sound. Dr. Oteño has an in-depth understanding of Kenya's and regional health and development landscape, having collaborated closely with national governments, NGOs, and donors across the region. He is the current chair of the MSM Health Research Consortium and has also conducted several trainings in Kenya, Uganda, Tanzania, Malawi, South Africa, and Zambia. He is published in peer-reviewed journals, presented in local and international conferences, and worked in technical working groups and roundtables to formulate, design, and disseminate policies and best practices. He also has a passion for emergency medicine and is a certified advanced trauma life support trainer by the American College of Surgeons, and is also an adjunct faculty at the Jomo Kenyatta University of Agriculture and Technology in their School of Public Health, where he teaches postgraduate courses. He is also an external research thesis supervisor in various universities. Dr. Oteño earned his MPH and PhD in public health epidemiology from the University of Western Cape, South Africa. He is a member of the Kenya National Academy of Sciences, as well as the African Academy of Science, and sits on the editorial board of several peer-reviewed journals. So as you can see, he has a lot of free time. Dr. Oteño, thank you again so much for taking your time to be with us today. We really appreciate it. We are absolutely delighted to have you, and we're looking forward to learning from your expertise. So thank you. And with that, let's get started with your presentation.
Thank you very much, Alison, and thank you very much, Keith, for agreeing to move the slides for us. So like Alison has said, I want to take us through what we call the Anza Mapema journey, and this is basically on how to start early on the HIV prevention, care, and treatment journey for gay, bisexual, and other men who have sex with men, as well as transgender persons in Kisumu, which is in Western Kenya. Next slide, Keith. So brief background on who Nyanza Reproductive Health Society is before we start. So this is a Kenyan organization that was established in the year 2002 when 3 universities, that's the University of Nairobi, the University of Illinois at Chicago, and the University of Manitoba, came together to start the randomized control study trial of male circumcision for reduction of HIV incidence. Remember, this is one of the 3 landmark trials that showed that VMMC as a procedure will reduce HIV incidence by up to 60%. So NRHS has been conducting research and also implementing programs on reproductive health and HIV prevention, care, and treatment with the remit of our work revolving around male circumcision, sexual and reproductive health studies, key population work, including work specifically with LGBTQI, lesbians, gay, bisexual, trans, queer, and intersex persons, which is what I will mostly be talking about today. In addition to that, we also conduct various epidemiological and observational studies within the same area, and we also have some clinical trials that are going on. Our work is mostly in Western Kenya. Kenya is within Africa, East Africa, and the Western Kenya region is in the western part of the country and encompasses former provinces of Nyanza and Western Province. Next, please. So NRHS as an organization runs 2 research and programming centers. So the first one, which is the longest serving, is the UNIM Research and Training Center. And this is where we do our work with the general population. And then we also have the Anza Mapema Center for Excellence, where we do work with our LGBTQ population. I'll talk briefly about these two in the next slides. Now, we have additional outreach facilities whenever our research is ongoing and we see the need of doing that. In doing our work, we actually collaborate with like-minded organizations, mostly in programming and research. And these organizations span the remit of organizations within the country, including the Kenyan Ministry of Health. We also collaborate with various universities within the US and Europe, for example, UIC that we are talking to today, University of Chicago, Rush and Northwestern that are all in Chicago. We also have University of Washington, we have University of Manitoba, Liverpool and Oxford University, among other universities, as well as international local NGOs. I can't finish the list right now. So the organization called NRHS is mainly divided into 3 main areas. One is the administration area that is headed by the head of finance. Then we have the programs area, and then we have the research area, and all these make up what NRHS is. Next slide, please. So briefly, within the UNIM and Research Training Center, so this is a state-of-the-art facility that was set up when NRHS was commencing the VMMC randomized control trials that I've talked about. Over the years, this center has grown to have space and expertise to be able to support multiple epidemiological and clinical trials. Also, it's able to support provision of programming, especially HIV and STI programming, including but not limited to voluntary medical male circumcision, early infant male circumcision, STI screening and treatment, among other services that we are offering. Next slide, please. The other facility we have, which is the Anza Mapema Center for Excellence, sits on a beautiful half-acre compound within a residential estate in middle-income Kisumu. It offers safety, tranquility of a residential house, as well as the state-of-the-art facility for research and programming with the LGBT community. Within it, we are able to offer a safe space that is welcoming, and we also have welcoming and affirming staff, as well as a welcoming and affirming environment that allows us not only to conduct our work with the LGBT community, but allows the LGBT community to be able to feel at home and feel part of the community that we offer services. Next. So today, I just want to talk about what we call the Anza Mapema platform, which is mainly located within the Anza Mapema Center for Excellence. The map on the slide basically shows us the 2 areas. We call them the constituencies of the sub-counties where Anza Mapema operates within, and that's the Kisumu Central Constituency and the Kisumu East Constituency or sub-county. These 2 are part of the 6 sub-counties that make up Kisumu County. So that is where the target area of Anza Mapema is. So just a brief background on why do we do this important work. So MSM are disproportionately affected by HIV and STIs with up to 3- and 5-fold increment in the prevalence when compared to general population. And we can see this in the 2012 Lancet paper by Breyer et al. Will be able to update us on more current information from the studies we have done. Next, please. And closer home, when we look at a paper done by Edward Sanders, who is one of our colleagues, who was based in the course, that evaluated HIV incidence compared between men who have sex with men, as well as compared to men who have sex with men as well as women, we find that there is as high as 26% incidence among men who have sex with men when they're compared to that. And also, the study showed us that having gonorrhea or chlamydia with a 3-month incidence of about 39.7 per 100 person years. Next. And next, please. Finally, being an MSM also has legal challenges within majority of African countries. Either they are declared as illegal with a jail term, or in extreme circumstances, sometimes you have countries applying the death penalty to being an MSM. Next. So the Kenya National AIDS Strategic Framework basically acknowledges these legal barriers, the stigma and negative provider attitudes that MSM tend to face within, with the resultant reduced access to care. Thus, they have declared MSM as a priority population in the fight of HIV. Now, within the Anza Mapema platform, we have various activities. What is on your left is our programmatic activities, and what is on our right is our research activities that are going on, and I will be able to build on the program, and then I'll also pick a few research activities to dwell on. Next. So if we look at our HIV prevention and treatment program, so this started as not something mainstream, but it started as during the male circumcision randomized control trial, as part of the social behavioral questionnaire. A few men identified themselves as men who were having sex with other men. And informal interviews with the investigators revealed the existence of a hidden community within the Kisumu catchment area that was otherwise underserved. And with this came the identification of the need for services within these communities, though at this point there were quite a lot of issues around confidentiality and security provided for this community. So the investigators at that time started having informal meetings with this community just to be able to understand what their needs were. So following that, in 2010, NRHS, in collaboration with UIC, completed a respondent-driven sampling study for the gay and bisexual MSM in Kisumu. The study initially started with 11 original seats, and in 6 months, they recruited 450 men aged between 18 and 63 years who reported either oral or anal sex with another man in the last 6 months. The study yielded an HIV prevalence of 14%, with the prevalence among 18 to 19-year-olds being 4.2% versus 28.9% among 25 to 29-year-olds. At this point, the male prevalence in the general population was ranging around 7%. Next slide. So then at the end of the RDS, there was a need that was identified by the community members of being able to have a group where they can be able to meet, share their experiences, and support each other. And with this, NRHS gave birth to what we call the Kisumu Initiative for Positive Empowerment, or TPE in short. And this was a status-neutral general support group that catered for both HIV positives and HIV negative men at that point. In a few years, this support group was able to rapidly grow, and by 2015, it was having about 350 active members. Then in 2015, NRHS got CDC funding to be able to start the Anza Mapema program, and this Anza Mapema program was actually a continuation of a research study that I'll talk about a little bit later. So within this program, we were able to continue offering the work that people was doing and expanded the membership to over 1,000. Then over the time, we've had inclusion of transgender persons, both men and women. Then in 2018, we received additional funding and an expanded mandate to offer comprehensive HIV prevention, care, and treatment services, first through LVCT Health in the STEPS program, and second through the CHEB program in the Entrenched program in 2018 and 2021, respectively. Next slide. So currently, the Anza Mapema program deems to provide a comprehensive HIV prevention, care, and treatment program for men who have sex with men, as well as transgender persons, to increase their access to and scale up of quality HIV prevention care and treatment interventions. Now, our program areas are majorly within the HIV prevention interventions, where we have social behavioral interventions, as well as biomedical interventions, including PrEP, PEP, and condoms and lube distribution. In addition to this, we have HIV testing services, which include self-test HIV testing, as well as PNS and SNS. We also have HIV care and treatment optimization services. We have sexually transmitted infection prevention, screening, and treatment. We have gender-based violence screening and also post-rape care for survivors. We have tuberculosis screening and referral for treatment, as well as viral hepatitis screening, vaccination, and treatment. Next slide, please. So one thing that we found out in the Anza Mapema study and were able to implement within the program is on social activities. So when we look at program services over time, so we were able to have a set of programmatic activities that within the study we're able to show that increased retention. And what we have, if you look at this, so we have a very packed week, and we say that on Mondays we watch movies, on Wednesday we drink coffee, on Thursday and Tuesdays we have therapy, then on Sunday we pray in church at St. Sebastian's, then one Friday every quarter we get to have a cultural day, and we get on Saturday to rest and sleep and recharge, waiting for the next week. So if we within the Anza Mapema study that I will talk about, we were able to evaluate these services just to be able to see how do they contribute to retention overall. So we realized that actually half of our participants attended at least one program event. It was a relatively low proportion for each. The median number of the visits per month was 4 for Movie Mondays, Coffee Wednesday, and for group therapy, while it was 3 for St. Sebastian. Now, overall, we had about 18% of our men receiving a referral, with the median number of referrals per month being 4. And referrals were mostly for either alcohol counseling or psychosocial counseling for psychosocial issues. Now, if you look at the Venn diagram on your right, which is a proportional Venn diagram, it shows that majority of the men attending the program visits actually had a great overlap, meaning that individual programs did not draw different sets of participants, but it's the same participants who tended to attend the same programs. Next slide. So for this slide and the next slide is just pictorials to show participants attending our social activities. So we talked about Movie Mondays. What happens in Movie Mondays is we have an infotainment session where participants or their peers pick a movie that they want to watch. So this movie will be screened. At the end of the screening of the movie, then there will be an interactive discussion on what we learned from the movie, because all the movies are thematic and educational. So what we learn from the movies and how that the participants will apply that in their day-to-day life. Then on Wednesday, we had Coffee Wednesday. So there has been, as we'll see from the Anza Mapema data, there's a lot of issues with alcohol intake within this population. So the Coffee Wednesday was a day in which you have the opportunity to instead of drinking alcohol, you are actually drinking coffee, but it has a 3-step system where the first step is the Standard Alcoholic Anonymous system, where clients go through the ASA, the 12-point AA sessions, and they'll be able to work through this. Now, there are those participants who probably their alcohol issues were more than what the AA would do. So the peers will identify this, and this will go into the second part of the program, which would be individualized based counseling and alcohol reduction program. Then the third category are the people who will now be referred for institutional alcohol reduction programs. Then for our group therapy, so on Tuesday we have group therapy specific for HIV. On Thursday we have group therapy specific for HIV infected individuals, and for Tuesday we have a status neutral group therapy. Within this group therapy, the clients are able to share and support themselves within either their HIV prevention journey or their HIV care and treatment journey. Next slide, please. Then at the bottom of your slide on the right, we have St. Sebastian session. So NRHS hosts one of the 2 LGBTQ affirming religious institutions within the country. The other one is in Nairobi. So within this, we tend to have different denominational preachers or pastors coming to be able to share the word of God with the LGBT community. And this came about across because as part of the work we were doing, especially qualitative work, we're able to understand that the group really wants to have an encounter with God, with their maker, but the mainstream churches technically are mostly homophobic, and they will not feel comfortable at that point. So that is why this started as an opportunity for that. Additionally, we have other activities that happen once in a year, like the World TB Day, the World AIDS Day, the HIV Candlelight Memorial, HIV Vaccines Day that we attend as part of our social activity. Next slide, please. So currently, within the entrenched HIV prevention program in Anza Mapema, we have so far enrolled 844 men who have sex with men in the program, with 781 currently active. Of these, 227 have ever initiated PrEP, with 149 who are currently active on PrEP. Now, of our 81 HIV positive men who have ever enrolled into care, 60 are currently active, and we have 97% viral suppression within that community. In the past 1 year, we have had 0 seroconversions over that year, and we hope to continue having those 0 seroconversions because we have a motto of 0 new infections. Now, within Anza Mapema, we have an Anza Mapema specific community advisory board, which is slightly different to what we have in UNIM. And this Anza Mapema community advisory board has membership from LGBTQ organizations, representation from the religious sector, representation from our law enforcement sector, from our legal and judicial organizations. Now, this community advisory board meets quarterly and provides a community eye to all our programmatic and research activities within Anza Mapema, where they'll be able to contribute to conceptualization of studies and the running. They'll be able to oversee the running of studies, and they'll also be able to contribute to our programmatic activities on how best to deliver this. Next, please. So now, within that program that is ongoing, we have been able to test 12 studies so far, and these studies range from epidemiological studies to clinical trials. And I would have loved to take us through all the 12 studies, but due to time constraints, I've picked 4 studies as a demonstration of our capacity of what we can do within Anza Mapema. And these 4 studies, 2 of the studies are studies that have been finished, and we have results for those. And 2 studies are studies that are actually starting in this year, 2024. Next slide, please. So one thing is, for each of our studies, we have the long scientific name. Then we also have a short name that is usually picked by the community that is catchy and is easier to remember. So the first study, which started in 2015, which we commonly refer to as the Anza Mapema study that gave rise to the Anza Mapema program, is actually a study that was evaluating expanding test and treat for HIV prevention in MSM in Kisumu, Kenya. The PI was myself, and it was funded by CDC and EPSA, which is a UK aid-funded South African-based organization. Next slide. So the Anza Mapema study was a longitudinal cohort study that targeted 700 HIV positive and HIV negative men who have sex with men and reported to have had sex with another man in the past 6 months. The study had 4 aims, and the first aim was to find and test 700 men who have sex with men for HIV. Following the identification, those who are HIV positive were to be linked and retained in HIV positive men, in HIV care and treatment at that point. Key to note at this point that test and treat had not started in this country, and the commencement of ART treatment was based on a CD4 count of below 500. So this was the first study in the country that was able to start patients on test and treat. Now, for those who are HIV negative, the third aim was to link them to an ART HIV prevention care and risk reduction program, which included retesting every 3 months just to be able to maintain the HIV negative status. Then with funding from EPSA, we were able to add a 4th objective that allowed us to look at uptake and adherence to HIV exposure prophylaxis. The study happened within 2 clinics of NRHS. One is the Anza Mapema Tomboya Clinic, which we have seen pictures of, and the other one was the Anza Mapema Town Clinic, which unfortunately we had to close due to funding constraints. The difference of these clinics was the Anza Mapema Tomboya Clinic is the more famous known one that has majority of our participants, who are actually out there, while the town clinic catered for the hidden population that was not yet out there. Now, for the study, we screened a total of 1,012 individuals. 75% of these were eligible, and of these 75%, we were able to enroll 94% of them. 89% of those enrolled were HIV negative, and we had 13 converters by the end of the follow-up period. I will talk about this a bit later on. Next slide. Now, our study procedures was the men would be mobilized in the community, then they would be brought within the study clinic. At the study clinic, they will be screened for eligibility to determine if they're eligible or not. Those who are eligible will go through an informed consenting process, and then they will be enrolled into the study. Then at baseline and every other quarterly visit, they will have a social behavioral risk assessment using an ACASI, which is an audio computer assisted self-interview. Then they will also have a quarterly medical evaluation, history and examination with specimen collections. We collected blood, we collected urine, and we collected rectal swabs. We used this for the HIV negatives. We tested for HIV, we tested for sexually transmitted infections, notably gonorrhea and chlamydia. And then we also did some hematology testing just to be able to look at the normal parameters. For those who are HIV positive, in addition to doing STI testing, we're also able to test them for their CD4 count and their viral loads, as well as safety monitoring for their drug taking. Both arms of participants who underwent quarterly risk reduction, with this risk reduction being tailored to their HIV status. Now, for those who are HIV positive and those who are HIV negative that were on PrEP, they had additional monthly visits for adherence, for monitoring of their uptakes, and also for their pill refills. Next slide. So what were our results? One was, this was one of the largest DBMSM cohorts at that time in Africa, and had a very high retention rate of above 80%. We experienced a lower than expected HIV prevalence of 11%, and with 72% of all our participants being newly tested. Now, this 11% was actually a design issue, because initially, as part of our mobilization, we were informing people that we were looking for those who were HIV negative. So if you knew your HIV status was positive, then we will enroll you into the program. So that is how we ended up having a lot of new testings. Now, the study was able to show us that there was an MSM and heterosexual convergence, especially with about 71% of our men reporting to have had sex with a female partner, with 50% reporting that this happened in the previous 3 months to their being enrolled in the study. Whereas we only had 51% of our participants reporting that, of those having sex with females, reporting that they used condoms during those sexual intercourse. Like I said, 65% of our participants reported to have taken alcohol in the past 1 year, with 50% of this being at harmful levels. 42% reported using recreational drugs, with 23% being at harmful levels. 31% of our participants reported having experienced childhood sexual abuse, which was related to a person in authority, with 11% reporting moderate to severe depression that required treatment. Of our 13 seroconverters, this gave us an HIV incidence of about 2.3 per 100 person years. And when for the participants who are on PrEP, we were able to note 98% adherence by report. But unfortunately, when we did tenofovir drug levels, we were able to detect only 47% of any tenofovir drug levels of the participants in the PrEP trial, with only 15% of our participants having any protective amount of PrEP within their system, which basically begs the question of, is adherence, is retention equal to adherence, which is equal to having drug levels within the system, which is another question that we ask in a different study. Next slide, please. So this slide presents urogenital gonorrhea and chlamydia among our study participants at 3 different time points. That is baseline, month 6, and 12 months. Now, the prevalence of urogenital Neisseria gonorrhea, which is green, I hope you're seeing green the way I'm seeing green, was 3.8% at baseline, 2% at month 6, and about 2.5% at month 12. While that of chlamydia in yellow was 10% at baseline, 5.4 at month 6, and 7.4 at month 12. And we see a cumulative prevalence of either or and chlamydia and gonorrhea at baseline of 12.4%, 7.1% at month 6, and 9.4% at month 12. Next slide, please. So if we look at additional, rectal and NG, if we added rectal and NG, rectal Neisseria gonorrhea and chlamydia trachomatis on top of the urogenital, so the additional bars are basically giving us the additional proportion of STIs that we have based on this. So this will give us an additional about 3.8% at baseline, 2% at month 6, and 2.4% at month 12. Next slide. Now the animated boxes below, basically show us the additional prevalence of rectal gonorrhea and rectal chlamydia infections, either at baseline, month 12, month 6, and month 12, as we have seen. And so we're also able to show that co-infection of urogenital gonorrhea and chlamydia was 10% at baseline, 3% at month 6, and 7% at month 12, with 23% of men with a baseline infection having a reinfection at month 6. And we query whether these were untreated or these were additional new infections from their partners. We also see that 29% of the men infected at month 6 were also infected at month 12. And there was 2 subjects that were actually infected across all the time points. Next slide. So key to note is that of all these gonorrhea and chlamydia infections, 25% are symptomatic and do not report any symptoms at all within the study. Next. So then we are switching gears to our second study, which started in 2019. We call it the Tatu Pamoja study, which is a demonstration study to assess the incidence of HIV as well as detention among HIV negative MSM and transgender women in 3 cities within Kisumu, and that is Kisumu within Kenya, sorry. That is Kisumu, Nairobi, and the coast. And this was funded by International AIDS Vaccine Initiative. Next slide, please. So the Tatu Pamoja is an observational cohort study that enrolled HIV negative MSM and transgender women from ongoing studies or program within the 3 areas that I've talked about. To be eligible, the participants had to be either between 18 and 29 years. And we intended to determine HIV incidence and detention and correlates to HIV-1 acquisitions. We also wanted to assess uptake and adherence to PrEP and also determine the prevalence of acute HIV infection. So the study initially started in 3 sites. That's Kisumu at the Anza Mapema Clinic on your left, Nairobi at the Swap Clinic in the middle, and then we also had the Mtwapa Cable Clinic in Kilifi. Then we also had additional clinic in Malindi for the Cambridge Clinic. Then 2 years later, we were able to open another site within Mombasa at the coast. So those 3 sites within the coast are counted as one. Next slide, please. Now, our follow-up was quarterly, and the procedures are divided at 3 different time points. If you all remember that between 2019, when the study started, and December 2022, when the study ended, something unique happened called COVID in the middle. So before COVID came, and we had lockdown procedures, that's between September 2019 and March 2022. We had enrolled 801 participants, and we were able to conduct iris scanning to prevent enrollment across the sites and also with other different studies. The participants went through quarterly ACASI questionnaires, like we saw in the Anza Mapema study. They also had quarterly HIV testing, acute HIV infection assessment, and we also had the HIV RNA testing done if they were eligible for that. We had a symptom-directed medical history and physical examination. Then we also had a PrEP eligibility assessment with initiation and refills for those who needed PrEP. We collected contact information to be able to follow up on these participants. Next. Now, the next time period was during the COVID-19 restrictions between April 2020 and September 2020. At this point, there was total lockdown in the country. You could not travel, you could not go anywhere else unless it was a hospital visitation. So even our staff could not come to work. So we paused the study, no activities happened. But what we did was we linked all our participants with CBOs offering HIV prevention services to MSM and TGW. especially for the course that did not have an HIV prevention care and treatment program within their study. Now, Nairobi and Kisumu already had this program, so the participants are linked to those programs, and the programs in their own unique ways were able to offer services to these persons. Next slide. So after the relaxations of the COVID-19 restrictions, that is between October 2020 and December 2023, we received follow-up. And the first thing we had to do was we started tracing the participants and invited them for study follow-up. So we resumed study follow-up. Then additionally, at that time point, we got additional funds to be able to do 2 time points of chlamydia and gonorrhea sampling collection and testing. So we will look at those results. Next slide. So for the study, we were able to look at estimate the date of infection, which we defined as the midpoint between a previously documented HIV negative visit and a subsequently documented HIV positive visit. We were able to estimate HIV as well as the median gonorrhea incidence rates and the 95% confidence interval. So these are a few characteristics for our participants that we are able to check. So we enrolled a total of 847 participants across all the 3 sites, and those are distributed as follows. We had an overall retention of 80%, with the highest retention being seen between Kisumu and Malindi. Our median age was 24 years, with a range of 22 to 26 years. 13% of our participants were identified as transgender women, with the highest being seen in Malindi at 28. 59% of our participants reported having had receptive anal intercourse, with the highest being seen in Kisumu at 66%. 60% of our participants reported having engaged in transactional sex, with the highest of 74% being seen in Malindi. 27% of our participants reported PrEP use, with the highest being seen in Mombasa and Mtwapa at 52%. I'm sorry about the seroconverters, they're not supposed to be percentages, so I think that's a typo error. So we had 3 seroconverters in Kisumu, 7 in Nairobi, 2 in Malindi, 10 in Mombasa, with an overall 22 seroconverters, giving us an overall incidence of 1.7, with the highest incidence being seen in Mombasa and Mtwapa of 5.0 per 100 per year. Next slide. So this slide presents chlamydia and gonorrhea infections by anatomical sites across the 4 different sites. So if we look at it, for rectal gonorrhea and chlamydia, we had 3% in Kisumu, 8% in Nairobi, 15% in Mtwapa, and 7% in Malindi. For urethral gonorrhea and chlamydia, we had the highest, 17% in Kisumu, and oropharyngeal gonorrhea and chlamydia, we had the highest percentage, or highest 9% in Mtwapa. And if we did a composite of any CTNG infection, we were able to see the highest in Mtwapa being 27%, with 18% second being followed. So that was baseline prevalent CTNG infections. Next, please. Now, when we look at the incident infections, which was testing done 6 months later, we're able still to see the highest incidence in Mtwapa for rectal CTNG, followed by the highest incidence also in Kisumu and Nairobi for urethral CTNG. Oropharyngeal CTNG was highest in Kisumu, and a composite for CTNG incidence across the sites. All the sites showed a very high incidence, except for Malindi that had a low incidence of 9%. Next, please. Now, there are 2 risk factors that are actually were able to be elucidated as risks to incident CTNG infections. And one was having a baseline CTNG infections, with those who had a baseline CTNG infection having a 3.2-fold chance of acquiring an incident infection. Now, the second risk factor was PrEP use. So those who reported that they were on PrEP had a 1.7-fold risk of acquiring an incident CTNG infection. Next slide, please. So that concludes the end of the two studies that we have done. So far, we have results for. Now, the next two studies I'm talking about are studies that are actually beginning this year, with the first one beginning in April, the second one will begin about July or August. So the first study, which we call the Mbili Pamoja study, as has been our tradition with all our studies, this is a study of the clinical history of rectal and urethral STIs among MSM, and we intend to characterize microbiome host immune interactions for diagnostic and vaccine advances. The PI for this study is Professor Mehta, also of UIC, and the study is an R01 funded by NIH. Next slide. So the goal of this study is to analyze host microbiome and immune responses to elucidate the clinical history of incident urethral and rectal chlamydia and gonorrhea infections among men who have sex with men within Kisumu. We intend to do this through three aims. One is to describe the clinical history of STIs in terms of bacterial community composition and function, as well as host immunity from time of detection, time of treatment, and time post-treatment, so at 3 different time points. Our second aim is to identify microbiome community compositions and specific tasks associated with STI incidence and symptomatic infection. Our third aim is to identify adaptive immune mechanisms that link microbiome, STI infections, and host immunity. So the study is a prospective cohort study that intends to enroll 500 men who have sex with men across 2 sites, and these 2 sites are the Kisumu site, which is in Nyanza Mapema, and the Nairobi site, which was part of the Tatu Pamoja study. Follow-up will be a period of 1 year with quarterly follow-up, with the half-yearly follow-up. Now, at baseline, we will, of course, screen for eligibility. Then we will have informed consent process. Then we will collect the following information at baseline, month 6 and month 12 from all participants. First, we will have a social behavioral interview that will be done using a CAS, as was in the Nyanza Mapema study and the Tatu Pamoja study. We'll have a dietary survey that will be staff administered. We'll have a network survey also that is staff administered, and we'll also have a psychosocial survey that will be staff administered. Additionally, we'll have a clinician conducted medical history and physical exam. And as part of this medical history and physical exam, we'll collect penile and rectal swabs, which we'll use for microbiome and also immunology characterizations. We will conduct HIV testing for chlamydia, gonorrhea, and HPV, and we will also offer treatment as required. We will do schistosomiasis testing only for the Kisumu site because of its proximity to the lake, which is one of the risk factors for schistosomiasis acquisition, which is not in Nairobi, and we also offer treatment for this. Additionally, we'll do bacterial community functional profiling through metatranscriptomic analysis, and we'll also do a mucosal cytokine measurement, a systemic memory, and activation markers. The next study, which will begin sometime in July, August of this year, is what we call the Mambo Matatu study, or the 3 things study. These are WHO recommended periodic presumptive treatment, which I will be talking about as PPT, versus a doxycycline post-exposure prophylaxis, which I call DoxyPrep, for STI control among cisgender MSM in Kenya. The PI is Professor Graham from University of Washington, and is also an R01 funded by NIH. So what is this Mambo Matatu study? So this is a rigorous study to evaluate the impact and cost effectiveness of WHO recommended PPT versus DoxyPrep compared to what we have as the standard syndromic treatment among Kenyan MSM. The study also has 3 aims, sorry. The first aim is being to evaluate the effectiveness and impact on antimicrobial resistance in gonorrhea of the 2 interventions, which is the WHO recommended PPT and DoxyPrep, which is given WHO PPT given every 3 months, DoxyPrep given 24 to 74 hours after condom-less sex, and these 2 are compared to standard syndromic treatment. The second aim is to assess the acceptability, feasibility, and safety of implementing the WHO recommended PPT and DoxyPrep compared to the standard treatment, syndromic treatment among providers and patients within Nyanza Mapema. And the third aim is to model health and economic impact of scaling up WHO recommended STI PPT and DoxyPrep compared to standard of care on STI control among MSM and their partners within Kisumu within Kisumu, Nairobi, and Kilifi, the same sites that were used for the 3-site study. Next slide. So the study will enroll 2,900 participants, randomized in the ratio of 2, 2, and 1, evenly distributed across the 3 sites with an equal number of 950 participants in each of the sites. Now, the 3 arms of the study, one will be the WHO recommended STI PPT, which will be evaluated at baseline and quarterly, and thereafter for STI PPT eligibility based on participants reporting having either had condomless anal sex or either multiple sex partners or a sex partner with an STI in the past 6 months. Our second intervention, which is the doxy post-exposure prophylaxis intervention or doxy-PEP intervention, participants will be provided with a 90-day supply of doxycycline quarterly. They'll be given one-on-one counseling on the self-administration of 200 milligrams oral doxycycline within 24 to 72 hours after condomless anal or vaginal sex, as frequently as daily if indicated, but not more than once daily. Now, our control arm, which is the standard care arm, these are participants who receive screening for STI symptoms at every scheduled visit, and scheduled visits are all quarterly, and they will receive syndromic treatment provided in accordance with the Kenyan guidelines. The concept diagram on your right basically takes us through the study activities with eligibility assessment to determine inclusion and exclusion at screening, enrollment, and randomization. Now, for the randomization, I said that we randomizing 2, 2, and 1. So 1,160 individuals will be allocated to doxy-PEP. 1,160 individuals will be allocated to WHO PPT, and 508 individuals allocated to the standard of care. So we'll have quarterly visits all the way through month 18. Now, for the participants in the doxy-PEP, they will have quarterly refills of doxycycline, with 90 pills being given. They will have quarterly ACASI with questions on sexual behavior, STI symptoms, and antibiotic use. They will also have quarterly rectal throat swabs and urine for gonorrhea and chlamydia, as well as blood for syphilis and hair samples for doxycycline levels. An analysis will be analyzed intention to treat. Now, for the participants who will be in the WHO PPT arm, they will have quarterly PPT administration, which will directly observe in the clinic. And the PPT administration will be a tablet of cefixime and azithromycin that they will get. And in case they are sensitive to cefixime, they will get an injection of ceftriaxone. Additionally, then they will have the same ACASI, the same samples being collected as the participants in the doxy-PEP arm. Now, the participants in the control arm, they will get a standard of care with syndromic treatment as indicated quarterly, and in case they come up for any other visit they want. The measurements will also be the same as the other two, and all the analysis will be intention to treat. Next slide. Keith, next slide. Okay, so the next 3 slides, which are basically my last slides, I want to talk about our collaborations. And in this picture, I believe you all know Professor Mehta, and the others are collaborators from, one is from LSTM, and the others from around Kisumu here. Next slide, please. So our collaborations mostly are with the Kenya National and County Ministry of Health. So the Kenyan health system is divided into 2, where we have the national health system that works within the country. Then we also have county ministries of health that also be able to look at delivery of services within. Additionally, we also collaborate with government agencies, including the National AIDS and STD Control Program, where we sit either in the community of experts or in the technical working groups to be able to provide expertise and support in implementations of not only programs, but also research. I would like to point out that for over the past 10 years, we have a UIC students program that has been going on, where every summer, UIC sends between 3 and 6 MPH students who come to Kisumu, and NRHS arranges for their homestays and also their placement within different research and program organizations or program institutions within Kisumu and within NRHS. And in certain instances, if it's a program that we don't have, we'll find one for them. And then this provides an opportunity to be able to either work on their capstones or on their projects, to be able to have the first-hand experience in developing countries. We have also been collaborating with numerous public health and medical researchers from around the globe. And we continue welcoming anyone who wishes to explore research possibilities in this area where the needs are great and the opportunities to make an impact are nearly endless and we cannot quantify. Next slide. When Alison was introducing me, she was able to say that I'm the current chair for what we call the MSM Health Research Consortium, or the MHRC. And this is a consortium that designs and implements studies that identify and address HIV, health, and other challenges faced by gay and bisexual men who have sex with men in East Africa. The MHRC has three main objectives. One is to strive to standardize data collection tools to enable the collection of data that is comparable across different studies and different study sites. And so far, we've been able to do this in 4 different studies. Second is to share and pool data following mutually agreed upon protocols that allow for analyzing, writing, and publishing results. And we have this in 3 studies. One is still ongoing. And finally, develop new innovative biomedical and behavioral research together or in collaboration with agreed upon partners, with the main goal of informing and assisting mainly the Kenyan Ministry of Health to improve HIV prevention, care, and treatment of MSM. And the last 2 studies that are presented, an example of this third aid. Next slide. So this is a list of our partners over the past 20 years that NRHS has existed. Some of these partners are development partners, some are scientific partners, and they're partners within the country, like Lumba Sub-County Hospital, where we are based, the Kisumu County Government, National AIDS and STD Control Program, to universities like UIC, University of Washington, and international organizations like UKAID, USAID, CDC, and also pharmaceutical companies like Viv Healthcare, Laboratory, Inotech, and MSD. Next slide. So I'd like to conclude at that point by saying thank you. And this is part of our staff. This picture was taken last year outside the Hanza Mapema Center for Excellence. And this was the staff just being together and saying we're ready to take on anything that comes our way. So at this point, I would like to stop there. And if there are, and we can take questions. I believe Keith will guide us on how we proceed with that. Thank you very much, and you're welcome.
Yes, thank you so much, Dr. Tenyo, to hear about the work you and NHRS is doing in Kenya. And we're very, very happy to partner with your organization and to send MPH students there to assist with your work and the development of their global public health career. So yes, if you have any questions for Dr. Tenyo, feel free to put them in the chat, or if you want to raise your hands and I will go to unmute you. So let's see if there's any questions. So not right now, but I did have one question to start off, Dr. Tenyo, because LGBTQI rights are still, there's still opposition to them in Kenya. How were you and your organization able to recruit so many participants and also create that trust that's needed there to retain that many?
So thank you very much, Keith. I will answer your question in 2 segments. So the divide of this segment is a year called 2010. So prior to 2010, in the old constitution, technically it outlawed being a gay person in this country. There was direct jail sentence for being gay. Now, during that time point, what happened was within the Ministry of Health, we were able to look at the LGBT community as having a health problem. And this health problem needed addressing, especially with the transaction we see between the HIV within the gay community and also the heterosexual community. So the Ministry of Health was able to drive this as a health agenda, with prevention, care, and treatment being the linchpin for that. So that is how we were able to provide services. Now, the 2010 Constitution, with the Bill of Rights in Article 2, basically said that you could not discriminate on anyone based on several things, one of them being their sexual orientation. So that has able to come with it some protection. Now, the penal code, which has not been repealed so far, that we inherited from the old constitution, still makes it illegal to be gay. Now, the only interesting thing is the level of evidence that would require someone to go to jail would be actually having an eyewitness to a sexual act between two people of the same sex. So that is how it is. So right now, there is a lot of programming and a lot of organizing within the community members, and they're able to not only organize with themselves, but also to have like-minded organizations like NRHS to be able to do this with them and for them. And I can say now, how do we build this trust? If you look back at the way I started my presentation back all the way in 2007, when NRHS realized, oh, there is a constituency that is not being addressed very well, and this is a constituency of men who reported they were having sex with fellow men. And NRHS started having initially informal support groups for them, then this grew formal in 2010, all the way up to right now, where we are offering services across the country. And our track record has been able to build trust, has also been able to show our care, has also been able to show us as being in touch with the community. So currently, as it is, we not only provide services, but we partner with community-based organizations, some of whom we host as their funding, and also we are able to mentor them and also work with them on this journey of providing services and also conducting research with the LGBTI community. Thank you.
Great, thank you so much. And I think we'll have time for one or two more questions. So if you have a question, please enter it in the chat. But one of the studies I noted that there wasn't a high percentage of condom usage. Is there still a, well, I guess not is there still, but is there a stigmatization against using condoms, or are individuals kind of hesitant to go out and purchase condoms?
So yes, there has been there. So initially, so if we look at it, we look at it two ways. One is so what I was able to show is about 70% of our participants report that they were, for as much as they were gay men who were having sex with men, they're also having sex with women. Then 50% of this was actually the past 3 months. Now, what we were able to show was only 51% of our participants reported that they used a condom when they were having sex with these women. So that by itself presents a risk that I cannot put a directionality to it. Initially, we used to say it was one direction, but probably it is bidirectional in terms of the risk of transmission of HIV, either from the gay community to the heterosexual community, the reverse, or both ways as it is. Then if I tie that to a question that is asked by Fanta Waterman and also another one by Dr. Bailey. So we start with Fanta, yes, we have PrEP programs. And within the program right now, I say we have 127 people who are going PrEP. And the impact that has been, I don't have current data for this year to be able to show what the impact of this has been. But if you look at in the past 1 year, we have been able not to have any HIV incidents. We can ascribe that partly to PrEP, but also partly to the other programs that we are doing. Now, if you look at the Anza Mapema study, we were able, within the PrEP sub-study, we were able to show that participants reported very good retention. They reported very good adherence. By retention, it means they kept all the study visits, so they came, they picked their drugs. When we measured adherence by either visual analog scale, we were able to get ranges in the ranges of 90. When we did pill counts and we did diary recalls, we were able to get 98%. Now, this was interesting because when we collected dry blood spots and we were able to test for tenofovir drug levels, 47% of our participants had any tenofovir in their system, with only 15% having any protective levels within their system. One of the studies that I have not highlighted here, but I can remember it offhand, is what we call the Your Choice study. So what we did was we were able to see after this and find out what is the problem. So within the Your Choice study, what we did was we asked participants a question of, if you had these 2 options plus these 3 hypothetical options, what would you choose in terms of PrEP? And the 2 options were condom use, daily PrEP, which is what existing, and the hypothetical issues were either a 3-monthly injection, a monthly pill, or an annual implant. If you had these options, what would you choose? Majority of our participants who are MSM or transgender persons actually chose a long-term method. And the reason for this is taking daily PrEP has a pill burden that most people don't like. And if we extrapolate this to the Anzamama study, what this tells us is our clients are well enlightened. They know what they're supposed to do. Thus, they know what they're supposed to tell us. So there's the social desirability angle about what they tell us. That's what we saw. Then Professor Dr. Bailey's question is, we showed that GBMSM on PrEP have about 1.7 times the risk of getting an STI compared to GBMSM when not on PrEP. There have been similar findings in various studies on MSM in the States. Do you think this is due to sexual distribution or risk compensation? I would say I think that is so, because one thing that happened is prior to PrEP, we used to tell people that to protect yourself from HIV, ABCs and D, so abstinence, be faithful, and use condoms consistently. Now, one thing we've seen with the advent of PrEP, as PrEP uptake increases, usage of condoms has been reduced. So then what this happens also over time that we've seen is STI prevalence and incidence, say the treatable ones, has been going up with the PrEP uptake. So that is why if you look at the data we saw from the Tatu Pamoja study, one of the results showed that actually men who are on PrEP had a 1.7 times the risk of getting an STI when they're compared to those who are not on PrEP. So yeah, that I will associate that with the risk compensation.
Great. Thank you so much, Dr. Otenya. So it's just a little bit after the hour, so we will have to bring this to a close. But again, thank you so much for joining us today. We really appreciate all your work you've done there and just sharing it with us over at UIC, sharing it with our students. So thank you so much, and thank you for all the great work you have been doing.
Also, thank you very much, Keith, and thank you very much to the audience for having taken time to listen to the work we do. And we'll continue doing this, and hopefully we'll get another chance to interact. If any person has any additional questions that we do not address right now, probably I think, Kate, they can drop them with you. You can drop me an email, and I'll ensure you get the responses for this. Thank you very much. And have either a good afternoon or a good evening, depending on which part of the world you are in.
Yes, thank you too. And thank you again to our audience for attending today. We hope you have a great rest of your day.